single tool which leads to wisdom. So wisdom is something which, gives us lot of solace and calm in our heart. And that gives a clarity in our brain as well. So having said that, thank you, each of you. I'll take this opportunity instead of introducing me, thanking all of you. I can see almost 600 brilliant minds here, and the air is full of jnana. Thank you so much. And it's your day. You have motivated us to do programs like this, get people from different part of the globe and different part of the city, and give you a clear-cut practical and evidence-based medicine, which will definitely, when you go back, some changes will happen in your practice as well. And end of the day, you'll all make a world a little better place to live happily. So AMH anxiety. Of course, it's an anxiety. I think you all relate with me, right? Having said that, we all know there is decline in fertility in the whole globe. It's not only in our country, it's a global problem. And what is the beauty of our country? We all know being a parent is not just a passion, it's a legacy. And sometimes for a lady who is deprived of this, it becomes a purpose of her life. Just holding the baby, we do see our couples and especially women coming in front of us sitting here. See, this is the last chance, madam. Forget about anything. My husband is ready. He is going to get married again. It becomes so important when we do see some people coming from different place and asking us this question. So then how do we deal with this? I think all of you will relate to me. This is a common scenario now, what we see in the clinic. Just recently married 1 or 2 years, they come in for a regular fertility checkup. And then, Madam Suman, Aruna Suman, Madam, why don't you please come on dais? I always like to see you here. Yeah. So when we see ladies like this, and we do a just normal scan, and when we do a scan, we just see 2 or 3 follicles. And then, of course, we do a test, AMH. And when AMH is less than 1, what happens next? How do we reveal this to the patient is also a little difficult situation for us. She is nice, she's there, she is having so much of aims in life. So her very question is, why did this happen to me? Actually, they say if there is very less eggs, there is some habit like I smoke or drink. No, I don't do that. What about my family? They don't have problem at all. All my sisters have kids. My mother has 4 kids. So what do I do now? Next is bigger question. Will I conceive naturally? And then is, do I need treatment? And last is, how can I get my result sorted? These are the questions, burning questions. These are the practical questions a lady comes and asks. Maybe if we are very busy, she may not ask, but it's in her mind burning. These are the questions which burns in her mind. Then how do we deal with? See, when you see patients, in maternity, you see a baby coming to you, you're very happy. But in fertility, they want to go with the baby. They're so anxious. And when they're anxious, and for us to sit in front of her and counsel her ethically, transparently, and what counseling plays a major role. So how do we counsel her? So myself, when I hear this question, I go back to studies and see data. Am I the only doctor facing this problem? In my own clinic, almost 30% of ladies have less AMH. 30% is a big number. How do I do? So we all know surrogate marker for ovarian reserve is AMH, and satisfactory fertility happens at the level of 2.2 to 4. Other than PCOS, I have not seen any lady having this AMH. I see most of them less than 1.51. This is what we are seeing now. Then better is to, whenever you counsel, you go back to studies. And studies about AMH is very important. You can't take the global study because ethnicity comes into picture. Our Indian women gene is different. So if you see this beautiful study which was conducted in Bangalore by our own Gunashila madam, she says that a lady is stepping into the clinic more than 30 years, almost, 25% of them will have decreased reserve. And what about lady more than 40 years? 76%. Do we know the magnitude of this problem? 3/4 of ladies after 40 years, their AMH is less. So what do we do now? Bigger question is, what do we do now? And then again, when she changes, if she's not happy with the doctor, she goes to another clinic, they start talking about so many terms. DOR, POI, POR, FOR, POF. What is all this? She's confused already. Now, how do we deal with this nomenclature? It's very simple. What is DOR? It is diminished ovarian reserve. That means for that particular age, the reserve is decreased. Now, POI is premature ovarian insufficiency. The ovary is not working efficiently. It is insufficiently working. What do we mean by that? A woman who is less than 40 years, she may have amenorrhea of 3 to 4 months and her FSH is more than 25 nanograms per deciliter. This is a diagnosis of POI. But these women, you can't tell you'll never conceive. The ovary suddenly becomes good and it starts working intermittently and she can spontaneously conceive as well. And what about POF? Premature ovarian failure is an old-time nomenclature. You can remove it from your dictionary. Next is POR and FOR. These are all responses when we do an IVF. How much she is responding and what is the follicle output ratio is the number of follicles what she get when we stimulate. So having said that, these are the nomenclature we should be aware of. Now is cause of AMH. When we have to explain her, when she's asking a reason, of course, a lot of things doesn't have explanation, but at least we should have a sound knowledge of what's happening in our country. So I was trying to do so many research and seeing what could be the reasons. There are plenty, but I don't have time to explain. Let me cut it short. Increasing age, all of you know. Then endometriosis, and then smoking. Obesity, 65% can have decreased AMH when an obese woman comes to you. Crazy it is actually. What about any chemotherapy? And what about autoimmune conditions? And then any surgical removal of ovaries. All these are there when you see her. Of course, lifestyle also plays a role. Then what next? We know the reasons. So this is one of a beautiful graph what we see here. If you see this graph, it says that when you do a day 2 scan, you see normally 10 follicles in both the ovaries. And ovulation, out of these 20, only one ovulates. We all know that. What is the fate of rest of the follicles is it will go for atresia, it dies. We all know that. But these are the recruited follicle. But background, what is happening? The unrecruited follicle, the pool of the follicles, it is so crazy. 1,000 follicles die per month. That is the magnitude. The women has the highest number of primordial follicle when she is in utero at 20 weeks. We all know that 6 million follicles she is blessed with. But when she is born, 1/6 of the follicle has already died. She is coming with 1 million follicles. She comes out. Then throughout her from puberty to menopause, only 500 follicles are every month released. But the end of 40 years, out of this pool, if you see, there is only 1,000 follicles left. So that is what is very important, how these follicles are, just running away. And in our country, what has happened, one major shift is age of marriage. If you see the census, 10 years back, age of marriage of ladies were 23. Now it is 29, 30. And what happens with this? The closure of window of fertility. The fertile time when she just can become pregnant, she has lost that bus. Now she gets married 30, 35 and they're not aware. And other crazy confusion is they see global data and they compare. My Spanish friend at 45, she's planning pregnancy. Why not me? This is the real questions what we have to answer. But in India, it is different. Our genes are different. We are very beautiful in many other ways. The colors what we have, what celebrate what we do, our rituals. But when it comes to ovary, somewhere, we are ahead, 6 years ahead. We have that data as well. So it's our responsibility to make them understand age definitely plays a role. So this was one beautiful study conducted by our own Manish Bankar sir along with Professor Velasco. Indian women with Spanish women. And it is proved, the previous speaker has also put this slide, 6.3 years we are racing ahead compared to the Western population. And then the study just ended saying 6.3, but I was more interested. Why? Why is that so? Why are our ovaries aging faster? But this was another study by Firuza Parekh madam. What she told was, what are the reasons for our women late 30s and late 20s and early 30s, they have so much less AMH? What is it? What is the reason? Let's dig into it. The world is changing, we all know that. And what are the food what we are eating? Adulterated food, we all know that. And especially these endocrine disrupting chemicals, we should have a little idea about this. Phthalates, biphenyls, BPA and parabens. These are, I think you're all hearing this because of the plastic ban. We should support our Prime Minister and our government in this whole hands for ban of plastic. Today I saw some plastic bottles. I was not actually very happy. I went and told them to change this plastic bottle. We all of us see each drop of water make a mighty ocean. All of us have to support for this plastic ban. Because reason is there. See, these plastic bottles contains this chemicals. And this was an interesting study. What they did was, it affects the whole HPO axis. I'm not going to other things restricting to pelvis. What happens to the uterus? What happens to vagina? And let me come to ovary here. If you see ovary, this was a good study where fetal ovary was incubated with these particles. And then BPA, they saw it kills the ovary. It decreases the ovarian reserve. So I will take you to this beautiful study I just got in the morning. In India, eradication of malaria was a big program then. This happened in almost 1948 till 1907, where for almost 30 years they were trying to ban malaria in our country. Of course, it's very important to ban malaria, but then what they were using was DDT, a chemical, which was in our water, what they drank, and in pesticides. And these women who took, see, maternal food influences the ovary, the fetal ovary, we all know. The women who took all these things, then these are the ladies who are coming to us in front of us with less ovarian reserve. But these are things which we can't change. We can't go back to past and change. But what is in our control is future. Make sure your kids don't go with plastic bottles. Make sure your family is not using. That's the first step we need to take. Now, yeah, that was also analysis of that study which said that it is really an anxiety not only for the patient, even we are the reproductive medicine specialists and gynecologists. We do have responsibilities for our women. So very important. Now, having said that, we know the reason. Next, let's see what we are supposed to do when she comes like this. We have to do something, right? We have to tell her something. We know the jnana, why it has happened. Next is about investigation. What do you do if AMH is less? Of course, you see an antral follicular count. Antral follicular count, sometime, you may see 10 follicles, but AMH is less than 1. What do I do? These are regular challenges what we had. Yesterday, Manish Bankar sir gave us jnana of one beautiful point. What he said was, antral follicular count says about that cycle. It comes, it gets recruited and that cycle. But AMH tells us about the reserve. These AMH are glycoproteins. They are covering all the follicles, not for it to recruit more, because it wants to preserve the ovary. But then AMH is more cycle independent. And AFC is cycle dependent. So every cycle, sometimes she may get good follicles. So we are fertility experts. When you all send patients to us, we see their scan with less AMH and we see the best time when she gets a good AFC count. Previous month, if she has 2-3 follicles, we think, okay, let us wait for another month. See if this month she has got 4 or 5, because every follicles increases the clinical pregnancy rates by 4.5%. It is a good number, right? It's very important. Then is management. We all know there is a problem with AMH. How do we deal with it? So, of course, when the reserve is less, we know her biological clock has started. She doesn't have time. She has to become genetic mother, something we have to do to her. And everything, the base is this concept. So early recourse to IVF is a debatable topic. Now AMH is less, we do get doctors telling, see, counseling couple can be done in a very pleasant way also, giving an assurance, scaring them less, because there are facilities. So what there happens, the whole family is shattered. AMH is late, now what to do, immediate IVF. But this was one interesting study, what I will show you. In COVID sometime was in certain situation, some kind of, for this study it was a blessing. Because of COVID, they could not do IVF. So for 6 months, they saw many people with less AMH conceived also. So they did a study here. What exactly it is shown is, in the period of COVID, I don't know what, stress or, you're together, you're bonded, all that is another question. But end of the day, what they showed in this study was, even if AMH is less in a younger woman, you can wait for some time. How much time? See, we can't simply tell patients, you wait for 1 year, 2 months, 3 months. You should have a backed up evidence to tell her. That's what we are all here for. So what does this evidence says? So, in a lady who is less than 35 years, you consider her as having normal AMH. Do a ovarian stimulation for 3 months. If she is not conceiving, go with IUI for 3 months. 180 days you have. A patient is sitting in front of you, less than 35 years. 180 days, try her, get pregnant with basic protocols. You don't have to immediately send her to us. We'll be very honest to you. Then next is, don't waste her time, because more than 180 days, it doesn't help, because by the time she comes to us, sometime she will not have any follicles. I always say, if there is no seed, how can we make a plant? Very tough situation. So you have to strike a balance here. And then if she is more than 35 years, if she wants her own gamete, please don't waste her time. She doesn't have time at all. And then this is also a good news for the patients. IVF, if it is less reserved, when we do IVF, we do have challenge. I don't want to get into IVF. We have coordination issues. Day 2 follicles we see, one is big, one is small. So we have to do some pre-treatment and get the follicles right. And we are also very happy because, how the world changed, knowledge helps us to change for better. So we are also doing kind of random start protocol, late luteal phase, wherever we said get the good crop. Day 2, if she comes with 2 follicles, if she is coming in late luteal phase with 5 follicles, I have got the good crop, because we all know, all studies says, the follicle, it has a wave. It is not only one wave, 3 or 4 waves she has in the cycle. So catch the best crop. And then what about adjuvants? You all know. See, when patient is asking too many questions, first you sit and write all the adjuvants, buying time. But if you have knowledge, whatever you are putting there, it gives lot of, satisfaction to you. Of course, ultra-CoQ, lot of studies have been told. It is a mitochondrial energizer. It slows down ovarian aging. See, it doesn't do something, but it slows down. Whatever has happened, it can't correct it. DHEA, lot of debate. Of course, we do also give DHEA to women, but of course, lot of studies has controversy and then conflicting evidence. And this is one paper which is very little close to my heart. T-transport trial came for testosterone. People were using testosterone a lot. So Nicholas Polizos and his team published in ISHRE and said that pre-treatment of testosterone with 5.5 for 2 months will not help. Don't use it. But then I was very happy. This paper from our own KD Nair sir little contradicted T-transport trial by saying that what dose they had used in T-transport was 5.5. The ideal dose is actually it's 12. So with that, we also see there is increase in the clinical pregnancy rate, significant. So we do use testosterone in our women, but end of the day, we should all know folliculogenesis is only 120 days. So nothing should be given more than 3 to 4 months. That's what we have to strike. I do know from global perspective, they don't believe in antioxidants. I can see they don't relate it. But again, our genes is different. At least not too many, but at least what few we have, we should not bombard our women with too much of unnecessary treatment. That's the whole challenge. Now, an old elderly lady, 41 years, comes to us and she wants pregnancy. What is new now? See, roses in December, everybody wants. There is always a debate between desires versus dilemma. So how do we deal with that? Of course, we all know the ovarian clock, and then I don't want to get into this. So these are some newer therapies, protocols, and some medicines which tries to, as a lady ages, the telomere shortens. That's what we know. But then there are newer medications which is coming, rapamycin, NAD, Resveratrol is something we have little started using it. What they say, it is available in wine. That's what, old saying they say. The lady who has wine in her hand, she grows younger. So it is resveratrol is in wine, and then melatonin we have, ultra-CoQ, NADH. All these are again, we need lot of evidence, but we have to use it with lot of caution until we have published data. And then next is something very important. So can we force our own, our women, especially this generation, Gen X, right? They all want Gen Z. Yeah, Gen Z want to get married late. What can we do for them? We should strike a balance. I'll tell you very honestly, 10 years before, I was not at all, I was not talking about oocyte cryopreservation. I never liked that subject. But I used to go and convince everybody, come on, it's time, 30 years, Indian women has to have a baby. But nowadays, interested in marrying so early, they don't want a kid so soon. So, but we know our, ethnicity, our race, so how do we communicate? So there comes a transformation. Initially, it was in celebrities' pocket, but it is the ovarian cryopreservation has become very strong now. See, end of the day, we should believe science. This technology is not, doesn't have any side effects. It's safe to the women. So a lady who wants her own gamete, I have changed myself and like, okay, I try best to tell her the truth. But if she is very adamant, go for oocyte cryopreservation. This is the last resort you have. So of course, how much is a question? When is a question? Ideally, in our scenario, less than 30 years is what better. If she comes at 40, 42, she has only one follicle. It becomes very challenging. Less than 30, if any lady comes and says to you, I don't want to get married for 10 more years, give her an option for oocyte cryopreservation. It should be, because she has to become a genetic mother, right? Just at least create awareness of this. Then is, of course, all the studies are here to refine our practice, not to define our practice. We have to have a balance, striking balance between evidence and what we tell our patients. And now we have tried everything. There is nothing left. What else? She's still 2 IVF failed. She has got 1 or 2 follicles. Yesterday somebody came and told, I have my relative 3 IVF cycles. She got only 2 oocytes. She still wants to become a genetic mother. So research keeps happening. So this is something not new, it's old, but newer aspect. I will tell you how it is made simple. So we all know about PRP, intra-ovarian PRP is talk of the town, but we should know a systematic way of doing this. So what PRP does is, basically the newer concept is, again, debate between PRP from a stem cell, or whenever we tell stem cell, we think we have to subject her for a bone marrow biopsy, which is very tedious, right? So there are ways where they, instead of stem cell, they collect 60 ml of blood from the women, and then they categorize it and get a stem cell, almost 60% stem cell in that blood, and then 40% growth factors along with the sealant, and it is taken gently and it is transferred to the ovary laparoscopically. There is a debate between transvaginal and laparoscopy. There are 2 people who believe in different ways. So laparoscopically makes little more sense, because the primordial follicle, see, when you're using stem cell, all that is primordial follicle is a proliferative cell. It takes 120 days to come out. But an endometrium is a somatic cell. Endometrium every 15 days, 1 month, it keeps changing. Now you have to go towards with laparoscopy to the cortex, where primordial cells are abundant, and then put this, this PRP there, which is rich of also stem cells. And this is a new hope, and lot of studies has been done and published also in Aspire recently, and we are also joining hands together for this study. Hope, because ethnicity is something which we should know that in our country what is existing has to also be shown outside. So this is also different modes of PRP where we are, and end of the day, take home message is, of course, AMH is not only an anxiety for the lady, for the family, it's also a kind of little anxiety for a consultant who sees them very repeatedly. Be in your counseling, empathy. Don't scare them the first time. It shatters their dream. Counsel them, tell them what all is available, And this is where we are, to try best to do for our own women and make their dream come true of having their own genetic material. Thank you so much.